acidosis, we looked on the board today. One of the main things is diabetes and kidney failure. Think about how common diabetes and kidney failure are. DaVita dialysis would not be out there if it wasn't a problem, okay? So think about whether it's acute or chronic. We're not gonna get so specific into those disorders. That's our next test where we talk about diabetes and kidney failure. But kind of knowing the cause and what that generally looks like is what I'm gonna ask in your test. So the basic things that go with it. So what does it look like? I'm actually going to put up what it actually looks like so we can see it. I'm a visual learner. Let's see if we can figure out, so based on metabolic acidosis, because I just kind of pull these out, right? And I kind of make them up as I go. Let's think as a class, what would the pH, PCO2, bicarb be for somebody that is uncompensated? Let's just do an uncompensated metabolic acidosis. So what would our pH have to be? Acidosis, and it's uncompensated. It's going to be less than 7.4, that's our first thing, and it's not going to be within range, right? So let's just do a 7.2, okay? Since it's a metabolic problem, your respiratory is not going to be opposite of your pH, right? That would make it a respiratory problem. So let's do it the same direction and put over the uncompensated, so we'll just do 36. Why did I choose 36? Uncompensated. So it's in range of 35 to 45 for that CO2, so the lungs are not trying to help. What would our bicarb be if it's a metabolic alkalosis? Or excuse me, acidosis. It's going to be low, right? Let's put 19 in. Then PO2, we'll just say for the sake of easy right now, let's just 8. I'm not going to put any hypoxemia on there. Okay, so this is what metabolic acidosis would look like. We know that this is low. This is normal, and this is low. So we have metabolic acidosis. What would make this partially compensated? So we keep our pH the same, right? Because that's only if it's compensated. Partially, this right here would have to be low. Why would it not be high? Because then we have a respiratory problem, remember? Respiratory opposite. So if this one became 30, we have a partially compensated now. Okay, what if I wanted to be compensated? See how I still am acidotic, but it's in range. So on your test, it's whatever you need to do to be successful. Look at the pH first, and it was between 7.35 to 7.45. It's either going to be normal, like all these are normals, acidosis to the point where it's compensated. Okay? There's only two options, compensated, normal. So if you have a normal pH in that range, it can't be partial. It just can't do that. Okay? So this person here is now compensated. Okay, that's what it would look like. So on this slide you can see that the pH is low and the bicarb is going to be low because we have a metabolic acidosis. What would cause this? So this is why when we look at compensation, your opposite factor that is not part of the process is trying to either bring more acid in or take more acid off, or to bring more bicarb in. So if this person is a metabolic acidosis, okay, circle the ones that it is, metabolic acidosis, what is my CO2 trying to do here? Are they breathing fast or slow? Let's start there. It's going fast because there's low CO2, which means that there's low carbon dioxide. So if I'm trying to blow off all the CO2, what am I trying to do? I'm trying to blow off all the acid, okay? So hopefully if I'm getting rid of acid, and my lungs are helping, you're trying to get bicarb to come up, okay? This person is still acidotic, of course, but we're trying to manipulate the opposite factor to help you. We're trying to compensate. There's always a body trying to do that. So if you have a patient that's uncompensated, they're going to be sicker. People that are not compensating, remember that AVG I sent around the room with that CO2 of like 200? He was even partially compensating. Someone that sick. So imagine someone that's uncompensated, probably near that death, because you can't live with some of these extreme cases. Okay? So your respiratory respiratory system is trying to help in this situation. They're trying to breathe faster to get rid of the acid in the body. So there's really 3 ways that you can have a cause here. So the first one for metabolic acidosis is that you have impaired renal elimination, meaning kidney failure. Acute versus chronic. Let's just talk briefly, just generalized, what is the difference between acute and chronic kidney failure?
Acute happens fast and slow.
Okay. Yep. So acute, you can have anyone in this room right now. And if you, let's see, for some reason got a really bad infection and your body went into shock, you could go into acute kidney failure, even though you had a perfectly good kidney 2 days ago. Okay, it's abrupt, it comes on, still severe, could definitely cause an acid-base imbalance. Hopefully it's reversible if you catch it early, okay? Chronic kidney disease, is it reversible? No, chronic kidney disease happens over years of typically hypertension, diabetes, high cholesterol. Those components in itself cause kidney failure. So, and genetics obviously plays a part. But if you have those over years, it's still gonna present the same way. Because if your kidneys are failing, what's the first symptom that says, I'm failing? Urine output, right? So these people do not pee out the excessive acid, right? It's because our body excretes the bad stuff and keeps ahead, or keeps inside the good stuff. So when someone is peeing, or if they're not peeing, that tells us that they are not eliminating what would need to be eliminated. So if someone has metabolic acidosis, a lot of acid in the body, normally their kidneys would be trying to get rid of it, but now you have kidney failure. So you're not able to expel that. So that's one way to get rid of acid is through the kidneys. So then it says a high anion gap acidosis. So on your CMP, or your basic metabolic panel, or the complete metabolic panel, there is a lab on there that says anion gap. I'm not sure if you've ever seen it before, but anion gap, you don't have to know the normal, but a high anion gap typically means you have a lot of acid in the body. So would we have a high anion gap for an acidotic or acidosis problem? Yes, that just means that there's a lot of acid, and in your body, this constant teeter-totter, if more acid prevails, the anion gap increases. When we get rid of acid, it goes back to that neutral, you're not gonna have a high anion gap anymore. What did I do? It just tells you what anion gap is, okay? Okay, excessive loss of bicarbonate. So when you have diarrhea, or if you have vomiting or NG suctioning, your body theoretically, yes, can get rid of acid, or it can get rid of the base. We don't know, there's no way for you to go into your stomach and say, okay, I'm gonna pinpoint this acid, take this base in equal amounts. Your body, and it's situational. Some people can have NG suctioning and do it neutral and not have a problem. Others are not as lucky. So typically you can have issues with the suctioning or vomiting or diarrhea with metabolic acidosis too. Notice we did the same thing for metabolic alkalosis. It was the same causes. That is one thing nice about this test is that a lot of causes when it comes to the intestine or that gastric acid is gonna be the same for metabolic acidosis and alkalosis. So if it's vomiting, diarrhea, and they're above. What is an ileostomy? Make sure we know what these are. Remember the pouch that comes out of your skin could be a colostomy, but ileostomy is higher up, so it tends to have more of that acid too in there. So people that have colostomy bags might have some imbalances. What's a fistula? Yep, that's what we're thinking more of, like in the arm. But a fistula is a connection between 2 things. So sometimes people can have fistulas inside of their intestine too, and they can expel through the body. Sometimes they have fistulas coming outside of their nephrostomy tubes, going out of their kidneys. So it has to do with that imbalance from elimination. What did I say about chloride for respiratory alkalosis? Don't worry about it. I'm not gonna ask anything on chloride on the test, okay? It has to do with the stomach contents inside of your body. That's where a lot of our chloride is found. But typically when we have an acid-base imbalance, we're gonna treat the sodium because chloride goes with it. But chloride levels can be increased, causing metabolic acidosis in itself. It has a lot to do with kidney failure. Okay. Start studying, you can compare an acidosis to an alkalosis when it comes to labs, and usually they're mere opposites of each other. So remember when we talked about respiratory alkalosis, that's when we went and ran, okay? There was one electrolyte that makes you feel paresthesia, the numbness and tingling. What is it? Calcium. Is calcium high or low in that situation? It's low. When you have low calcium levels, it makes you have tetany, that contraction, okay? So if we have an acidosis problem, no matter if it's metabolic or respiratory, we tend to have higher calcium, okay? It's an exact opposite. So when people have metabolic acidosis, you're not gonna have low calcium, you're gonna have high. So we know calcium helps with contraction in the body, and if it's low, you're gonna be stimulated and start to contract, have high reflexes. What happens when you have high calcium? The opposite effect. And look what it says here. Depressed muscle contraction. So I'm going to give you an example of when we give calcium with moms in labor. Okay? Our uterus is a muscle. Okay? When we give, when people have preterm labor, what is their uterus doing? It's contracting. We can give calcium for it, calcium chloride. So we can give calcium for people that have that tetany. It kind of calms down the muscle. But when people have a metabolic acidosis that's very severe, their calcium levels tend to naturally rise, and it starts to depress all their muscles, and it causes almost like paralysis of their muscles. Okay, it's not a good thing. If you have paralyzed skeletal muscles, yes, you can see that, but what about your heart? If my heart's not contracting the way it should, what's going to happen to cardiac output? It's going to depress. They're not going to have as much contractility there as well. And then the same thing goes for any other kind of muscle inside of your body. So calcium on your test, I will be asking. Chloride, I will not. So if you have an alkalosis problem, your calcium is low. If you have an acidosis problem, your calcium is going to be high. And the only way I can really help you remember that is that if you think about how you felt with respiratory alkalosis, the numbness, tingling, okay, those are because of low calcium levels. So I just know all the acidosis are the opposite. Okay, that's kind of how I remember that. Okay, why would potassium be high in acidosis? Okay, because when you think about alkalosis, that's when our potassium was low. So when you have a person that has DKA, diabetic ketoacidosis, they tend to have pretty high potassium levels. I'm talking like 5 to 6s if it's a really bad situation. But they tend to retain the potassium because they're not having it expelled in like their urine, for example. They retain it, chronic kidney disease. If you were to take their labs, their potassium is always super high because they can't pee out the potassium. Lasix, remember that medication that helps you pee? What is one thing we always get concerned with? Hypokalemia. They get rid of the potassium. If I'm not peeing, there's nowhere for your potassium to go. So these people retain a lot more potassium. Okay, and then your calcium and your magnesium levels will be, or excuse me, your calcium will be high, your magnesium will be low. I did put that down here too. Okay, so risk factors, why would we have it? So here are whys. On your table that in Canvas that said, why are the reasons for metabolic acidosis? This is the blueprint for your test. These are the reasons you're going to look for when it says, here are your acid-base imbalance or your interpretation. Let's say I put this one on the test. You're going to have to interpret it and say, yep, it's a metabolic acidosis, but then you're going to have to ask yourself, what could cause this? So the top ones on the list should be kidney failure and diabetes. And then you can go into saying, okay, if I got rid of too much base in my stomach, I could go into a metabolic acidosis with diarrhea, NG suctioning, or potentially even diarrhea if that was the case. Okay, what about this one? What kind of shock could be caused? Think of lactic acidosis. Lactic acid is released from our muscles when it's stressed or when you have hypoxia, right? So what kind of shock could cause metabolic acidosis because of tissue hypoxia? So if I'm releasing lactic acid, remember what kind of shocks can cause that? Septic shock, yep, septic shock is one. Even hypovolemic shock. If you have no fluid and you're not perfusing your muscles, you could potentially have hypoxia from that lack of fluid. Which, if you think about shock in general, when you release lactic acid, you're causing an acidosis. Like that kind of makes sense. All right, down below, you can kind of see all the different things that you might exhibit, but when you memorize these, I want you to think about the person that has the problem, because this is general symptoms for any type of acidosis, for metabolic, but if you were to say DKA, I want you to be able to write down, what do they look like, what kind of things do they have? Because that to me is more important than saying, well, I know that people with metabolic acidosis have GI manifestations. That's just not good enough, right? So we want to think about the person, what do they look like, and how that would affect that person.
When you say like, this is the last slide, like internal suctioning, you mean like the stomach?
So yeah, like the NG suction, when you put a tube down your throat or into your esophagus to suck out the acid or base.
Why would it, like if it's in the stomach and you like suck out the acid in there, why would it make it like?
Because I can't, when you pull something out, your body has base and acid in there. It depends on how much was pulled out of your stomach. So if you think about a person that has an NG suctioning tube, it is heavily acidic, but there's also base in your stomach. So if they're sucking out the stomach, they might pull out more base or more acid depending on what they're suctioning out, or two in equal forms. So yes, there is the potential for an acid or base problem, but if I were to put NG and Erica and Amara, I can't pinpoint how much of their specific bodies are pulled out of equal values. So therefore, you can pull out too much base or you can pull out too much acid, but I don't know what concentration they have in their stomach. Yep. So yeah, I understand that you're thinking, well, it's all acidic, so if I take that out, it's taking rid of the acid. But there is base in your stomach too. It's not just acid. Good question though. Okay, so let's start with DKA, because that, we'll kind of talk about the manifestations. So when we have someone with diabetic ketoacidosis and they have a metabolic acidosis with that, we already talked about their breathing patterns. Okay, it kind of goes with like the respiratory, but what do they have for a respiratory component? Has anyone ever taken care of a DKA patient? Maybe you can help. So the first thing I think about diabetic ketoacidosis is their blood sugars. That's the first thing that should come up into your vocabulary. Their blood sugars are high, okay? And the reason why is because they don't have what in their body? Insulin, okay? So if there's no insulin in your body, you must have insulin in your body to get blood sugar into a cell. If it cannot get into your cells, it just dumps into your kidneys and therefore brings fluid with it. So I would expect to see high blood sugar, your 3 Ps, which are polyuria, polydipsia, which is what? You're thirsty. And if you think about it, if you're really thirsty, what's your mouth feel like? You're dry, right? Dry mouth. Polyphagia. What's polyphagia? You're hungry. Think about when your blood sugar gets low, you get hungry, right? So the polyphagia is because, yes, you have a lot of blood sugar or sugar inside your blood, but it can't get into your cells. It's just kind of circulating. So when I take your blood sample for a glucose stick, I see it's really high, but it can't get or feed your cells. So the reason why you have polyphagia is because although I have all the sugar, I can't use it because I don't have insulin. That's why they get hungry. So polyphagia, polydipsia, polyuria, they're going to have dry mouth, or just be dry in general, dehydration. And then they're probably going to have, obviously urine output's going to be increased. They're dumping all that out of there. Okay, breathing pattern wise, why does Kussmaul respirations occur? Because on the test you can say, yep, I remember Kussmaul respirations for DKA, but why are they breathing fast? Why can't they just stop? Compensating, right? I hate to say this, but is it a good thing that they're breathing fast? Yes, if they're able to compensate. So if this was our person with metabolic acidosis, they're trying to breathe fast to expel CO2, which is acid, because we don't want to be acidic anymore. We're trying to get back to neutral. So if you breathe really fast, you're blowing off acid to get rid of the acid problem in your body. Okay, so that's kind of the pathophys behind it. Okay, let's talk about kidney failure. So what do people with kidney failure tend to look like on assessment, or what kind of things do they present with? What did you say? I think Max said. What did you say? Edema. Okay, so why do you have edema with kidney failure? You have no urine output to get the fluid out. So typically they have anuria, no urine. So that is how potassium is lost. That's why they retain potassium. So you might have a potassium level then when people have kidney failure, if this fluid is kind of circulating, they might have increased blood pressure, right? Because all this fluid, they have to cause more pressure to pump it around. The blood pressure increases. Okay, skin changes. Now this is getting a little in-depth, but when people have stuff in their urine that should be expelled, it's like the bad stuff, right? That stuff circulates throughout their whole body, and they can actually have something called uremic frost. For a second, I want you to Google it on your iPad. Uremic frost. What this basically is like your nitrogen and ammonia from your body cycling through your body and causing this to go on the skin. Uremic frost. Look it up. Those are kind of like the skin changes that you might see with kidney failure. With DKA, they have dry skin. Why do they have dry skin in DKA? They're so dehydrated. They're peeing out all that fluid. The uremic frost just has kind of, can't really see it that well, but like a white crystalline on the skin, and it's because they can't pee and it circles through their skin. In a really bad case. Okay, kidney failure in its worst or severe form, and people that have DKA, they have an ill feeling. Because now, if this acid base is occurring, they're not going to be feeling well either because of the retention of a lot of the things that should be expelled from their body. So high blood sugars, they can cause them to feel just ill, nauseousness. They might even get a little out of whack, like their level of consciousness can be affected too. But the main thing is knowing what's the cause, what do they look like? Because someone that has DKA is not going to have uremic frost, right? That's not their problem. Or someone that has kidney failure, are their blood sugars going to be 500? Probably not, right? So think of the cause and then think of that treatment. What's the only cause or treatment for kidney disease? It's not a cure. You can have transplants, don't get me wrong. But like, what are the day-to-day treatments for it? Dialysis, right? So that's the only thing you can do for kidney failure. Do acute kidney failure patients get dialysis? Like the person that was on the interstate, they got into hypovolemic shock, and their kidneys failed for a week. Yes, they do. They have inpatient dialysis. And the reason why is because can we live without our kidneys getting rid of stuff for a week? Can't, okay? And sometimes it takes weeks to get back to where you were. So people that have acute kidney injury could have dialysis short term to get them back to where they need to go. Okay, and then these are the things that you probably would look at focusing on reversing. So what are the electrolytes that we just talked about for metabolic acidosis? Let's start with potassium. Will be high or low? High. Calcium will be high. Well, that's good, at least you get 2 highs. Actually, so will chloride be high. So maybe that's how you memorize that too. But they were all high in that regard. Okay, here's the treatment. So we have a person over here on the side that has metabolic acidosis. If you were to look at your pH, it's low, it's acidotic. The HCO3 is our bicarb, right? That's the bicarbonate in our body. If our bicarb is low and it's an acid-based problem that's acid, it would make sense to give a base or some type of medication that would make it more basic. So this person might potentially get to have sodium bicarbonate. Who would we not give sodium bicarb to for acid-base imbalance? People that have what problem with acid-base? Alkalosis, right? Because alkalosis means more base. So one thing that students tend to, I think they're thinking too hard, but after they sit back and think about what they did on the test, they're like, well, that makes sense. Because if we have a bicarb up here of 30, that's a lot of base, right? We don't give bicarbonate for high bicarbs. That makes no sense. But if the acid in the body is higher or the bicarbonate is low, meaning there's not a lot of base, we could give sodium bicarb to help that. So the only real thing that we have in the hospital besides sodium bicarb is fixing the cause. That is the initial thing you should do is fix the DKA or fix the kidneys, get dialysis. But let's say they're so sick with DKA that we don't have time to wait 6-12 hours. We might have to give sodium bicarb in severe situations where it's very, very problematic. Okay? Some people are chronically acidic. So let's say you have chronic kidney failure and their acid base always looks like this. They might be on medication orally for sodium bicarbonate, it's a pill, or if it's an acute state in the hospital, they will have IV. Okay, so sodium bicarb is our choice. I do not ask this on your test, just so you know. Okay, you can give this, but it's just not as commonly given. Those are solutions that are considered more basic that they can give to those people. Notice my bolding sodium bicarb. Okay, so here are some of the choices for why this would happen. Notice they all have the word acid in the term. So you have diabetic ketoacidosis, alcoholic ketoacidosis, and lactic acidosis. So what is lactic acidosis? Why would someone have lactic acidosis? There's only one reason. Shock, right? You only produce lactic acid in your body if your tissues or your muscles are deprived of oxygen, which is with shock. So we have to fix the underlying cause. Septic shock versus hypovolemic shock. What do you think the treatment differences are? Let's go septic shock first. It's an infection, right? Sepsis is an infection, so antibiotics, probably some fluids in there. Let's say hypovolemia, say they lost a bunch of blood. Giving blood. What if it's dehydration? Will blood help? No, give fluids, right? So treat the cause and what's going on. For this test, don't forget about your basics, okay? I think we get so caught up in the acid base, when you forgot about what the cause was, you could fix those issues, okay? Alcoholic ketoacidosis, this kind of goes with when people have, they can tend to offset their body with, if you drink a lot of alcohol in one sitting, their blood sugars can become very high, and that can cause them to kind of have, they don't have diabetes, but it causes their blood sugars to become super high. And so it could be from that reason too. Think about people that have, a ton of sugary drinks, and it's just like a lot. It also causes your cells to go into starvation mode. It doesn't actually get into those cells. And so those people tend to have like a reflex hypoglycemia, because your body goes crazy because there's so much sugar, and it produces a ton of extra insulin and actually makes them hypoglycemic. It's why when you wake up in the morning after drinking and you're like the most starving you've ever been in your entire life, right? You're like super hungry when you're hungover. That's why that happens, because your body was so used to all that sugary content of the alcohol that it produces way more insulin than normal, and you become hypoglycemic. So you almost even might get shaky. That's what happens. That's why the treatment is glucose. Okay, because probably you're like, well, that don't make sense. Why would their blood sugars be super high and get glucose? It's because because they don't have diabetes, they produce too much of their insulin, and it makes them become hypoglycemic. It does happen to people that don't have diabetes. Okay, here's our kind of renal failure. What are we going to do about it? It kind of depends on how bad they actually have it, but I have seen some chronic kidney patients on just every single day they get a pill of sodium bicarb. And it's because they probably are compensated because they're so used to having kidney failure, and they get that pill every single day to help their chronic issue with that bicarbonate. And then what if the person comes in with diarrhea? We're probably going to replace fluid and electrolytes. And what if it was C. diff? What would you do for C. diff? Yep, it's a bacteria, so we give antibiotics for C. diff. What do we not give for C. diff? There was one med that you will never give for C. diff. Remember farm? If I said, if you have C. diff, you cannot give this, because some people will see 10, 12 bowel movements a day, and they'll want to go to the Walmart and get this over the counter to stop the diarrhea. Yep, like Imodium or anti-diarrheals. We don't want to stop the diarrhea that comes with C. diff. We want to replace fluids and kind of help them with the infection, but if you stop the diarrhea from C. diff, it's a bacteria. So we don't want the bacteria to brew inside of that gastrointestinal tract. So we just kind of treat the fluid and electrolytes and then give antibiotics. And then the reason I put this flu, I'm not talking about, you can have diarrhea with influenza. I'm talking like the flu bug. Like when people say, I got the flu, but really it's just a GI bug. It's more like a gastritis, would be more what you'd say. So what would you do if someone was having a lot of diarrhea, but it wasn't from like C. diff, it wasn't from like COVID or something. It's just like they got a little bug in their stomach. Drink lots of fluids, right? Rest, drink fluids, and if you're getting really a lot of diarrhea, you might have to have intravenous fluids if that was the case. But replace those electrolytes and that fluid. Okay. With the nursing process, remember this is our ADPI. So I've gone through all the content with metabolic acidosis. Now it divides it into, if you have these problems, what does the assessment look like? What are some of the nursing diagnoses? And what are you going to do as nurses? I would say most of your tests for any of these acid-base imbalances comes from these slides forward. It's like, okay, now I know what the problem is. kind of what it looks like, what do I do about it? Or what are the things that I might see on a test for nursing interventions, okay? So knowing what's going on. So in some cases, you're not gonna have acid base to look at, right? Would you agree that if a person comes in with chronic kidney failure and they're not having that much problems breathing, do they tend to collect acid base or ABGs on every patient? No. So that's why knowing the cause of the most common acid base imbalances is important, because sometimes we don't have acid bases to look at, or the ABGs itself. Think about your patients you've taken care of at the hospital. How often have you had a chance to look at ABGs? Not very common, right? It's not something we do on every patient. But how many of you have taken care of someone with diabetes, or taken care of someone with chronic kidney failure? So this is why we have to realize that I may not have ABGs to look at, but I know that chronic kidney failure and people with diabetic ketoacidosis tend to have metabolic acidosis. See how we kind of learn the cause and the treatment, but it's not so much about the ABG, okay? So we kind of just use our scavenger hunt assessment skills, right? Figuring out, asking the question, what the problems are, what they have. How many people do you think get CBCs and BMPs in the hospital? Every single one, right? We do that on literally every person that comes in. So if you are on your BMP and we look at our electrolytes or our anti-GAP or some of the things that confirm blood sugar, we can use that for our labs in our assessment skill and not the ABG. The only time we do an ABG is if one problem's happening. They're not breathing well, okay? And the reason why is because maybe it's an acid-based problem with respiratory, or they're compensating and causing the respiratory component. So most of the time we don't collect an ABG until that happens. So look for the cause and then we fix the problem. So underneath here, I kind of just showed you things that they might exhibit for problems with different issues. So if you look at that for kidney failure or the diabetes, but I always like to know or ask the patient, is this new or old? Because that's going to change a lot about what's going on. If they said I've been having diarrhea for 24 hours versus I've had diabetes for 20 years, we have a lot different problem going on. Or if the kidney failure is from an acute accident on the highway, that's going to be a lot different too on how it progresses. Most people don't go into kidney failure unless they have other predisposition of those risk factors. Okay? What about medications? What kind of medications might come up with diabetes and kidney failure? Yeah, maybe they're already on insulin at home because we have type 1 or type 2 diabetes. Most of the time people with type 1 diabetes are the only ones on insulin. However, are there some patients that could be on insulin with type 2? Yes, it's only when it becomes very bad. But type 1 always has insulin, okay? DKA is only referring to type 1 diabetics. Why is that? How come DKA can't happen in type 2 diabetes? There's one component. Type 1 makes zero insulin, none. Their pancreas has no functioning, zero, okay? Type 2 diabetes just have a lot of adipose tissue and it can kind of clog up, but they physically can still produce insulin. So their medications work on more just getting rid of the insulin or trying to expel that from the pancreas. It doesn't matter what pill we give to a type 1 diabetic, you can't make insulin, right? You have to supply that exogenously or through injections of the skin. So I like to see kind of what kind of diabetes they have because that can affect too what you do for treatment. Okay, and then with kidney failure, what if their potassium is always this high? Because can people with chronic kidney disease have potassiums that are always high? Yes. Okay, it's going to happen because they're not peeing outside that thing too. Sometimes we do give patients with kidney medications to get rid of potassium. Does anyone know how we get potassium lower? And it's not Lasix, because remember guys, their kidneys don't work. So you can't give Lasix to someone that has no kidney function. Do you remember what we gave? I talked about on farm. You can lower your potassium levels without like a weak diuretic. And so what they do is, can they still poop? Yes, because remember, we get rid of potassium actually 3 ways. Poop, vomiting, or pee. If I can't pee, I have to get rid of it through poop. I'm not necessarily going to give them a laxative because I don't want them to have a fluid and electrolyte imbalance, but I might want them to have a couple extra stools over the next couple days to get rid of potassium. Remember Polystyrene, it's a medication that can lower potassium levels. We give it to kidney failure patients all the time. Another thing that we can do, and this happens to kidney failure patients, we give them insulin with glucose. Why would we give, or dextrose, it doesn't matter what kind of glucose. Why would we give someone with kidney failure, not diabetic, this person does not have diabetes, kidney failure, why would we give insulin with glucose to someone that has kidney failure for high potassium levels? What does insulin do to potassium? Potassium normally is located within your cell. So remember the little softball analogy I used for you? The strikeout is a K with like a circle. Potassium belongs in the cell. When you take a lab from your blood and the needle goes into your vein, it's pulling the extracellular fluid, is what it's doing. So what it does is normally it should be in the cell, so you get all these potassiums that are outside the cell, and insulin helps it go back where it belongs. So when you draw this sample, you're not gonna have as much potassium. So what does insulin do to potassium levels when you get labbed? It lowers it. So we can give insulin as a treatment for very high potassium levels, okay? What about DKA? If I gave a whole bunch of insulin to someone that has a blood sugar of 600, what's it gonna do to their blood sugar, or their potassium levels? It's gonna make it drop, okay? So we have to be very careful with giving insulin to patients that have potassiums that are not high. Okay, I think we've talked about a lot of these already. What do you think someone's vital signs would be with DKA? Think about they're hypovolemic because they are peeing out a lot. What are the two things? Blood pressure, heart rate. What do you think they would be? High heart rate and low blood pressure. That just goes back to hypovolemia. So if you think about what they present with, you can figure out the vital signs. Let's think about vital signs with someone that has kidney failure. They're retaining a bunch of fluid, so their blood pressure is going to be high. See how you can still have a metabolic acidosis problem, but the vital signs are not the same. Okay. Urine output also is different. With diabetic ketoacidosis, their urine output is a lot. Kidney failure is low. Okay, here's a couple of nursing diagnoses that might come up. But notice where it says risk for excessive fluid volume, or if there's fluid volume excess, am I talking about your diabetic patient? No, I'm talking about your kidney failure patient, that one. You could probably say fluid volume deficit for the person that has diabetes. Okay? Why is there decreased cardiac output? That has to do with your calcium levels. So your calcium might be high and cause contractility to be low because your muscles are not stimulated. And then last one is injury. Why would someone have an injury from having these issues? It goes back to their cognitive status. If they become altered level of consciousness, okay? They could have a fall from it. So if the person had cardiac problems, how would we assess for a cardiac issue? What if someone's potassium from diabetic or chronic kidney disease was 8? What would your EKG show? So think about high potassium with EKG changes. What kind of T wave? Really high, right? Peak T waves could be on your cardiac. So let's say on your test you have a person with chronic kidney disease presents with severe metabolic acidosis, okay? And their potassium comes back at 8. Which of the following treatments would you do for this patient? See how it's not really about the ABG analysis, it's about the chronic kidney disease with that acid basin problem, okay? So we might potentially put tele on that person or watch their heart more often. Okay, fluid volume, if you have excess or deficit. So if you were to have two patients up here in the front, one has fluid volume deficit, one has fluid volume excess, could you theoretically say that everything is opposite? Probably, okay? So if you have vital signs for the deficit, you're gonna have the low blood pressure. For fluid volume excess, you're gonna have high blood pressure. Remember CVPs, central venous pressure? And it directly looks at your fluid volume status. What would be a CVP for someone with fluid volume deficit? Be low, right? Lower than 2. What about chronic kidney failure and they have fluid volume excess? It'd be high. Okay. And then someone already mentioned edema, chronic kidney failure, and then monitoring lung sounds. What would lung sounds sound like with someone with fluid volume excess? Potentially crackles from the fluid excess. This kind of goes with your fluid electrolytes as well, but looking at urine output, why is it hourly and not per shift. So we usually do our eyes and nose pretty routinely, once every 8 hours or so. Sometimes every 12 and something. Because if you had a kidney failure patient and they're not making you pee, or if you had diabetic acidosis and they're dumping urine, I need to know how much fluid is coming out pretty routinely to know kind of what the treatment would be for that patient. Okay? The only time diabetics are going to work is usually the first 24 hours after acute kidney failure. They will do like a Lasix or something like that for when the first injury occurs to see if the urine comes out, but if nothing happens, they probably have to have dialysis. What about daily weights? Let's think with chronic kidney disease. If you did daily weights and you saw an increase every day, you're probably not getting the dialysis that you need, or maybe they're starting to get to that point where they might need dialysis. You should not be gaining too much weight, you're gaining too much fluid, or the edema is really bad. We're getting there, guys. Okay, just some things for risk for injury. This goes back to probably your first nursing school or nursing class of how to prevent falls. But I do want to put this in your vocabulary for the test because you might have a patient with any of these acid-base imbalances that has a risk for falls. How do we prevent falls from happening? So making sure like the side rails are both up, the collites within reach, making sure that you hourly round at minimum to make sure that they're okay, and then maybe reorienting them as needed if that's the problem. What does the word stupor mean? This one comes up every year. People don't know what that means. They're like almost lethargic. They're not responsive to you, okay? So if you come in at 8 in the morning, is chipper and happy, by 10 o'clock they're just kind of drowsy, and by noon they're barely able to respond, that is a big change in status. So we have to make sure that changes in acid base, that would be a reason why we would maybe order an ABG for our patient, because they're not cognitively responsive, okay? And then these kind of things, a lot of education. Think about diabetics for the first time. I think there was a patient down in Parkston that one of you took care of. He was like in his 20s and he got diagnosed with diabetes for the first time. And he had to go home to try to prevent DKA. Think how much education that goes with that. You're gonna have to educate on doing blood sugars, telling how much is high or low, the foods that you eat, exercise, right? Those are all things that go with preventing them from coming in with DKA and having a really bad outcome. Okay? Or if someone has an ileostomy for the first time, knowing those things. Okay? So metabolic acidosis. Think about the cause, think about treating the cause, and then if you think about some of the things that the person looks like with those issues, that's gonna help you a lot for the test. So those are all the acid-base imbalances, and on Wednesday we'll kind of put it all together, and we're gonna keep just like asking you the same questions. That's why every time we come to class, we spend a half hour just on interpreting EEGs,